Good morning. I'm Dr. Dale Bratzler. I'm the Enterprise Chief Quality Officer here at OU Health, and I'm also the University Chief COVID Officer. Just going to give you a quick update on where we're at in Oklahoma, then try to answer a few questions. I also want to highlight a few kind of interesting studies I've seen over the past few days that I think are relevant to some of the things that we're seeing in Oklahoma right now. So I know most of the news outlets now track the number of cases that we have in the state. Yesterday we're just under 104,000, so I would assume that even within, while I'm speaking, we may go over 104,000 cases, confirmed cases in the state, with 1,143 deaths. I think most notably to me is that we saw 8,200 new cases in the past 7 days, which is one of the highest numbers I've seen, and we had more than 50 deaths again in the past week. One of the questions I was asked this week was, the Institute for Health Metrics and Evaluation has predicted that Oklahoma might have as many as 1,450 deaths by Thanksgiving. We're what, about 6 weeks out, 5 to 6 weeks out now from Thanksgiving, and we're seeing about 50 or more cases, deaths per week in our state. So I think it's important to recognize that at the current pace, we'll be pretty close to 1,400 deaths by Thanksgiving unless we see a dramatic reduction in the number of deaths in our state. 7-day rolling average of new cases right now is at 1,182, which is the highest that we've been during the entire pandemic. And as I've highlighted now a couple of times, we've seen a fairly dramatic shift in the hot spots in the state for new COVID cases. And while Oklahoma County, Tulsa County, and Cleveland County are most populous counties, continue to have the most cases on a daily basis, when you look at the population incidence, we have many rural counties that are now seeing more cases per population than our urban counties. So again, the disease is spreading throughout the state, and we've seen that in the Midwestern United States. I think Missouri, Wisconsin, North and South Dakota are all seeing very substantial rural spread of COVID-19. We're not different. This week, in terms of testing for the past 4 weeks has been up fairly dramatically, the number of tests, but we've been quite consistent. So as of yesterday, through yesterday of this week, 8.9% of the specimens that were tested came back positive, and that number has been fairly consistent now for the past 4 to 5 weeks. We've been in that 8.5% to 9% range of positive tests. So we're not seeing that number go down. And of course, the news that everybody's been talking about is hospitalizations. We had a new peak yesterday of 793 people in the hospital. Of those, 735 had a confirmed case, and of the confirmed cases, there were 278 people in the intensive care unit. And so that has put a strain on hospitals. I think most people are aware that because of the population that we have in Oklahoma County and this immediate region, including Canadian, Cleveland County, that's where we have the most cases. And so the hospitals in the Oklahoma City Metroplex have been most strained at this time and have had limited ICU beds available. A lot of people have asked where we're at with respect to hospital beds. There are still hospital beds available. One of the challenges has been staffing of hospital beds. Oklahoma is a nursing shortage state, and so having enough nurses to take care and staff all of those hospital beds has been a bit of a challenge, and I know that many of the Oklahoma hospitals are trying everything they can to recruit part-time, ad hoc, anybody that they can in terms of nursing to help them staff the additional beds that are necessary for COVID-19. So that's where we're at with respect to the data. Not too many surprises. We're continuing to see substantial community spread of the virus, which brings me then to a few studies or things that I saw in the news this week that I thought were particularly important. First one I'll highlight is one that came out this morning. It came out in the CDC's publication Morbidity Mortality Weekly Report, and it was a report from Florida of a hockey game of adults that had an amateur league. They came together to play hockey. It had one person who about 2 days after the game started having symptoms, got tested, was positive. They then did contact tracing, and out of that group, they found that 8 out of that particular person's team members tested positive. 5 out of the 11 members of the other team tested positive, and one of the people that actually ran the ice rink tested positive. What it highlighted again was some of the concerns of contact or close sports, and they noted that many of these players were very, very close to each other. Anybody that's watched hockey knows that happens. They weren't wearing masks, and of course, they were not doing routine testing. And one of the things I've highlighted for high school athletics, primary school athletics, and others is that when you start looking at why is it safe for the NBA to complete a season or the NFL to be playing or the Big 12 conference, remember those players are tested very, very frequently. The NBA in the bubble tested the players every single day. The Big 12 requires all of the athletes, the student athletes, to be tested at least 3 times a week. Primary schools, secondary schools, high schools, they don't have the luxury of doing that testing. And so amateur sports, high school sports, and other things are setups for potential spread of the virus because you cannot, there just isn't the funding to do all of that testing on those teams to keep them from spreading the virus in that group. So I wanted to highlight again, it's a good example of community spread of the virus. The person who got infected first in Florida at that hockey game certainly didn't mean to spread the virus. He had no symptoms when he was playing the game. His symptoms didn't develop for the next 2 days. But we know that for 2 to 3 days before you have symptoms, you shed the virus and can infect other people. So an important lesson to remember with respect to community outbreak of the disease. The second one was a study that came out from the Health Cost Institute. One of the things that I've been interested in my role at the College of Public Health is what has been the financial impact of the pandemic. And in this particular study, they looked at years of life lost due to the pandemic. When you look at the age of the patients who were infected, what their expected life expectancy was, they saw substantial years left. In fact, they saw 1.9 million years of life lost during the pandemic to date. But the important thing that they noted was that at the first of the pandemic, the years of life lost were less because it was primarily elderly people who were dying. But since June, they noticed that there's been a shift with more younger people dying, and those people have much more productive years of life in front of them. So the economic impact of this particular virus is going to be incredibly substantial just when you look at the number of years of life lost from the pandemic. So an interesting study that shows some of the severe impact of the disease. Another interesting study that came out this week, again, highlighted something that we've seen now in a couple of studies before. People with type O blood appear to be slightly less susceptible to the infection. In a very large study from Denmark, where they had blood type data on a large population of people, they showed that people with type O blood were about 13% less likely to get COVID-19 than people with A, B, or AB blood. However, having type O blood, if you got infected, didn't confer any protection. It didn't give you any particular protection with respect to the severity of the illness. But this is just a confirmation of several studies that have before shown that for whatever reason, probably due to antibodies that circulate in the blood of people with type O blood, that they seem to get the infection a bit less often than people with type A, type B, or AB blood. So just another interesting study. And then finally, I read a quote from the Associated Press this week that came from Governor Christie, and he basically said that he was wrong to not wear a mask at the White House. And he basically highlighted that, he thought going to the White House, he was going to a safe place where the grounds where people had been tested and he didn't have to worry about the infection. But what it did was raise for me an issue that I've pointed out in a number of interviews and also in a number of lectures. I don't care whether you're going to school, the office, the clinic, to your workplace, to the grocery store, or even to the White House. You may encounter somebody who is infected with COVID-19. Because remember that almost half the people who get the infection have no symptoms. They look normal. Even if they got tested, the test could be a false negative. You cannot screen people out of your place of business, your work. So you have to assume that anybody you encounter could be infected. And that's why we're encouraging people to wear a mask, to watch your physical distance from other people, to wash your hands. Those are the ways that we prevent the spread of this disease, something I'm calling universal COVID precautions. Anybody you encounter, you have to assume could be infected regardless of where you're at, and you need to wear your mask, do frequent hand hygiene, and remember social distancing. So I'll be happy to answer questions.
So one reporter was asking quite a few questions while you were talking, so they're related to what you were saying. First he said, have we had multiple days of double-digit deaths? Then expanded on that to say there are 1,472 new cases and 11 deaths. Talk about the multiple days of double-digit deaths.
Well, so I've highlighted this before. When you have more than 200 people in the intensive care unit with COVID-19, double-digit deaths doesn't surprise me at all. I think care in hospitals has gotten much better than it used to be. But when you look at some of the original published studies on the death rate for people who are sick from COVID-19 who end up in an ICU, studies suggested that 20 to 30% of those people died in the hospital. Maybe a bit better now because of better treatments, but the point is we had almost 300 people in the hospital and ICUs yesterday. We're going to continue to see extra deaths in our state. The other thing is yesterday there were 11 deaths that were reported, and I was able to look at the data for that group of patients. Only two of them came from a long-term care facility. The other 9 were from the community. And so just because you're not in a long-term care facility doesn't give you any particular safety from this disease. So that's why the Institute for Health Metrics and Evaluation has estimated that by Thanksgiving we could easily be at 1,451 deaths in Oklahoma. And if we continue to see 50 to 60 new deaths per week in our state, if we don't slow the spread of this particular virus, we could easily get there.
I wanted to know, what does the spike in hospitalizations mean to you? More people, symptoms are worse, and do you see it slowing?
Yeah, so it has been interesting because obviously anytime we're seeing anywhere from more than 1,000 new cases a day, we're going to see a percentage of those people end up in the hospital. Early in the pandemic, we typically saw 10 to 12% of the people who tested positive ended up in the hospital. I believe it's lower now, maybe around 8% or so. But if you have 1,000 a day, that means 80 people are going to be hospitalized in Oklahoma. So the only way to slow hospitalizations is to slow the spread of the disease. That's why the hospitals have been calling for people to start taking this seriously, wear their mask, do social distancing. This isn't political, it's not denominational, it's not anybody trying to tell you what to do. It's trying to make you safe, protect yourself and protect the people around you. That's why the hospitals are really pushing for more people to do the things that we know that slow the spread of the disease. And as long as we keep having so many new cases in our state, we're going to see more hospitalizations of people. And you have to be pretty sick to get admitted to the hospital with COVID-19. Usually struggling with your breathing would be the most common reason that you'd end up in the hospital. But when you're that sick, you get in the hospital, a certain percentage of those people will be in the ICU, and a certain percentage of those patients will die.
Okay, and was the 1472, is that yesterday's number, or
1470, it may be to, it may be.
Are you aware of the new number, 1472 new cases? I guess it was just announced.
Yeah, as I said at the start of this conference, that I had, they typically announce at about 11 o'clock, so I knew while we were speaking they would give us a number. 1472 is a big number.
Can you address why the state has such a bad nursing shortage? I mean, that's really a national thing, right?
Yeah, so there is a national shortage of nurses, but Oklahoma's been particularly hard hit with nursing shortage for years, long before the pandemic happened. So over time, there's been a little bit less interest in the nursing career. You had a lot of nurses that were retiring prematurely. That accounted for some of the nursing shortage. You know, our nursing schools are trying hard, but they can't keep up with the demand for new nurses on our state. So we need people to be interested in nursing as a profession. It's a great job, obviously, right now. It's a great field to get into because of the need for nurses in our healthcare system.
Cassandra wanted to know if the CARES Act dollars address that at all. Do they address the nursing situation or help the nursing situation?
Yeah, I can't comment about the CARES Act dollar, whether they actually have afforded anything around nursing education.
Okay, I saw actually this was me, I saw that there were a third case that was confirmed of a person that had already had COVID before, second time they got it.
Yeah, so there was a second person in the United States that had supposedly recovered from COVID-19, got a second infection. I think this particular person died. We just don't know yet what the rate of reinfection is with this particular virus. There have been a few cases where they've kept genetic material from the first infection and have been able to demonstrate that the second infection was a genetically distinct type of the COVID-19 virus. But we just don't know how often it happens. It's being reported more commonly. Now, remember, the vast majority of people who get COVID-19, we have not seen reinfections occurring. But you cannot assume that you have long-term immunity. You probably do for some short-term period of time, but you cannot assume long-term immunity. So it's very, very important that you continue to practice social distancing and wearing a mask.
Explain, let's see, okay, being a level 1 trauma center here in the metro, has that put a strain on our ICU with COVID patients and then trying to accept other patients?
Yeah, so OU Health and OU Health University of Oklahoma Medical Center is a level 1 trauma center, and I think many know that we've had restricted bed capacity for a long time. We've been at near 100% occupancy for several years now, and so trauma is a big part of the ICU population of patients that we admit. And so now to have COVID-19 cases on top of the typical thing, patients that fill up our hospital like trauma patients, patients with cancer, it has put a real strain. That's why OU Medicine announced about a week ago that we opened up one of the floors of our new bed tower to expand capacity to allow us to continue to provide care for patients with trauma and cancer and COVID.
Okay, if Oklahoma keeps going in this direction, do we think that hospitals will need to cut back on elective surgeries again?
Yeah, I think it's possible. The question is, if we keep heading in this direction, if we keep seeing such large spikes of new cases on a daily basis, are we going to have to cut back on some things that are elective? And I think that's certainly a possibility. It's one of the steps that might be implemented as part of the response to a large number of cases in the hospital. I know our hospital is already looking at, sometimes how you define elective surgery is in the mind of the beholder, and some may feel like theirs should be done more urgently. So, but it is a possibility that if we continue to see stress on the hospitals, increased number of cases, that there would be no other option other than to start cutting back on things like elective operations and elective preventive care, which is sad because I think a lot of us worry that if people don't get screened for things like breast cancer and colon cancer, that down the road we could see consequences of that in patients presenting with those diseases in much more advanced stages.
Could you summarize, let's see, I think you've done that already, summarize the hospital situation pretty much. talked about additional hospital beds here at OU. Some of these questions are the same. As one of the top doctors in our state, are you frustrated by the state's response to COVID?
Well, I'm flattered that somebody would call me a top doctor, but I think many of us, there's a group of us that are meeting regularly now called the Healthier Oklahoma Coalition, which includes the state medical associations, Hospital Association, Nursing Association, and others. We meet regularly to talk about the current situation in our state. And I think all of us are frustrated about some of the lack of interventions to prevent the spread of the disease. Part of it's personal responsibility, getting people to quit arguing about whether masks are safe or the other things that simply have no bearing in any science at all. I've been a strong proponent for a mandatory mask mask ordinances in our state, or having a statewide mask mandate, mainly because there's pretty good data, even from our own state health department, that in those communities that have implemented those ordinances, they see slower growth of the number of new cases. It's not perfect. Mask wearing only works if you wear them over your nose and mouth. So just because we have a mask mandate doesn't mean that it's easy to enforce or that everybody will do it. I understand that. But we know that in those places that have put the mandates into place, it seems to have slowed the spread of the disease. And quite honestly, I could argue that on a national basis, that nationally we're seeing more than 50,000 new cases a day in the United States. We crossed over 8 million confirmed cases in our country yesterday. We're not doing a good job right now slowing the spread of this virus. We saw from the study I mentioned earlier, the number of years of life lost from this disease. The economic impact of this disease is incredible. So we can continue to go along and just keep waiting and hoping that we get a vaccine out, or we could do more aggressive things to slow the spread of the disease and to save people's lives.
I saw on the news last night that even a European, I didn't catch which European country they were talking about, but maybe it was Italy, and they were saying that they had felt like they had gotten everything under control, so they opened it back up, and now they're having this big surge again, or they loosened things, and so it's not time to loosen things even if you get it under control.
So Europe has seen some upsurge in the number of cases because they started reopening their economy. And again, I think people get complacent with some of the things that we know works. So people were pretty good for a while about avoiding crowds and other things, but we haven't stayed consistent about doing that, wearing masks and those other public health practices that'll slow the spread of the disease. I get it. I'm tired of it too. But I want to protect the people around me, and I want protection for my family. So we wear a mask, and we wear them all the time.
This just came in that, is there a concern that neighboring states like Texas, which are bigger, are slowing down, and Oklahoma is still on the rise?
Yeah, so Oklahoma, I think, was number 9 in the nation in terms of new cases in the White House Task Force report this week. I saw yesterday that Missouri had their largest peak of new cases since the start of the pandemic. North Dakota, South Dakota, and Wisconsin are states that have incredibly high rates of new cases. It's moved to the center of the country, the Midwest, and it's moved to rural Oklahoma and rural parts of other states. And that's where it's spreading. And many areas of our state, I think people felt like they were protected because maybe they live far apart. They forget that you come together for religious services, for restaurants, to shop, and those are where people are getting infected.
Why is it so important to be transparent during this time?
Well, I think transparency is the best thing we can do right now. Let people understand where this disease is spreading, how many cases, what the reality is around hospitalization. Right now, it's difficult sometimes even at a hospital for an emergency room doctor, for instance, to know where there's a hospital that has a bed available without just making a bunch of phone calls. I think we need to continue to have as much transparency as we can. It's part of the reason our Healthier Oklahoma Coalition has asked for more transparency on bed capacity in hospitals, so that we know So a physician working in a hospital somewhere can know where they can send a patient if they have a patient that they're not capable of taking care of anymore.
Well, and that's something you were talking about coalition. I had heard people talking yesterday that the hospitals across the state really are working together right now. I mean, they're trying to let each other know what's going on and do just exactly what you're saying, right?
Right. So all the hospitals in the state are required to report to the state health department on a daily basis the number of beds available. That information is at the health department, but it's not broadly available other than the daily, here's the statewide number of hospital beds and other things. The state map that looks at the risk level looks at hospitalizations at a regional level, but again, because you could have some hospitals, could be smaller community hospitals that have beds available, that region of the state doesn't end up in the red zone. So I just don't think we're getting the complete picture of what's actually happening with respect to the ability of hospitals. I think the one thing that patients may find out is that if they have a serious medical condition, and it might not even be COVID, they may end up getting transferred to a different hospital or even to a different community to receive their care if the hospital's filled up. And again, I can't overstate that we are approaching flu season. If we see bad flu outbreaks on top of what we're seeing with COVID, then we could quickly overwhelm our hospitals with patients in the hospital setting.
So that leads to this question that just came in about what should we look for, expect in the vaccine distribution plan? I know that I've seen that there's places that are doing a lot, starting to do clinical or people trials with them.
Well, of course, the clinical trials are ongoing. Several of them are in phase 3, and I would assume that we would start to see some of the phase 3 results reasonably soon. I'm not a part of the group that's putting together the state's response plan for distribution of the vaccine. That was due to the CDC, I think, either yesterday or today. But I do know that when you look at almost every recommendation, it will be frontline responders, paramedics, nurses, doctors, people that are taking care of COVID patients. They'll be the first priority for the vaccine because they're at such high risk of getting the infection. And then from there, it's likely that the triage or prioritization of the vaccine will go to patients who are in high-risk categories, who have underlying illness or are older people that are more likely to die if they get the disease. Again, we've talked about before, 93% of the deaths from COVID-19 in Oklahoma are in patients 55 years of age and older. So you would think that that would be a priority group after you get your first responders, healthcare workers vaccinated. So I know there's a group of some very good people that are working on that plan.
You talked about the possibility of the projections for Oklahoma having more than 1,400 deaths by Thanksgiving. Can you just go into that a little bit more in detail? At the rate we're going, do you think that's going to happen?
Well, so I've been watching it. So we're at just over 1,100 cases as of yesterday. I haven't seen today's number, I guess 11 more deaths. But what I've seen is that we've been seeing on average about 50 to 60 new deaths per week in Oklahoma. And I think that number may go up just because we have so many people that are sick enough to be in the hospital. When you're that sick, your risk of death goes up. So I think that we may see that death number go up. Even if we're what, 4 weeks, I can't remember exactly, but we're either 4 or 5 weeks out from Thanksgiving right now, and you see 50 more deaths a day. I mean, we're talking 200, perhaps 250 more people die by Thanksgiving. We're quickly approaching 1,400 deaths in our state. So I don't think the Institute for Health Metrics and Evaluation is too far off, at least based on the current spread of the virus.
I know that here, and I'm sure at all the hospitals, that if the bed availability changes even hourly, I mean, because discharging and you're whatever. So Corey at the Tulsa World was saying he heard rumors that there were no ICU beds overnight in the state, at least at one point. I mean, what happens if we have no ICU beds in the state?
Yeah, so I don't think I could confirm that we had no ICU beds in the state. Last time I looked at the state health department report, there were about 100 to just over 100, maybe 110 ICU beds that were still open in the state. Now, they're not in the Oklahoma City metroplex. And that's where we've had the biggest shortage of hospital beds. And if you look at the state health department's map, you'll see that the Oklahoma City area has the highest number of hospitalizations. But there were still hospital beds in other parts of the state that were available. Again, though, it highlights the point I made earlier, that if you come into a hospital with a serious condition, there's a possibility, particularly if you needed ICU care, that you may be transferred either to another hospital within that city or even possibly outside of that city to another hospital to receive care. There just isn't an abundance of ICU beds available, particularly in the Oklahoma City metro area. Tulsa actually did have some a few days ago. I haven't looked at their numbers in a few days.
And I think you touched on this already, but what regional hospital data should the state make public to help hospitals and medical professionals as well as inform the public? Is there anything that we're missing?
Well, I can just tell you what we've asked for, and that's some hospital level, not regional, but hospital level data on both capacity, which includes ICU debt, something simple. Nothing that's based on it. It has to be staffed capacity. Many hospitals have more licensed beds than they have staffed beds. So what we really need to know is, on a hospital by hospital basis, how many staffed beds are available and how many of those are ICU beds. That makes it easier for a physician in a community setting to know where they can send a patient if they're really sick. That makes it easier for a regional or a rural hospital that's looking to get a patient who's very sick with COVID-19 or any other medical condition for that matter, to know where there are beds available without making phone calls, several phone calls to individual hospitals.
Looks like it. Anything you want to add?
Get your flu shot. It's that time of the year.